everyone. I am Sunshine Gray. As Emily said, I'm a nurse educator and I work for Fred Hutch Cancer Center, and I have been in cancer. I've been a nurse in cancer therapy for about 20 years, and I have about 11 years now of radiation oncology experience. And I'm extremely happy to talk to you today about radiation dermatitis. Today, we are going to talk a little bit about the pathophysiology and epidemiology of radiation dermatitis, the risk factors and ways to prevent, the ways that we do prevent radiation dermatitis, nursing assessment, diagnosis, and grading, and planning, implementation, and documentation. So first, we'll start with the pathophysiology and epidemiology, and I'm going to go a little bit remedial, so this might take you back to your anatomy and physiology class. But first, I want to say that skin cells are highly radiosensitive. So the keratinocytes that you see in your skin, which is what you see when you look down at your arms and your face, most of what are keratinocytes. They make up over 90% of the cells of the epidermis, which is the outermost layer of your skin. So the purpose of these keratin-producing cells is to protect against microbial, viral, and fungal parasitic invasion, also protect against ultraviolet radiation, and to minimize heat and water loss. So the basal keratinocytes, the stem cells and the hair follicles, and the melanocytes are the most radiosensitive that we have in our skin. Radiation treatment is one of the many factors that can cause formation of free radicals. During radiation therapy, tissue damage begins at the very first fraction and causes immediate structure tissue damage. As you can see here, we can form free radicals from many different sources, and ionizing radiation, which is what we give in radiation therapy, is only one of those sources. Radiation therapy causes ionization of cellular water, resulting in free radicals, and free radicals are unstable atoms with unpaired electrons in their outer shell that seek other atoms or molecules to bond to. So as they continue to accumulate, this begins a process called oxidative stress, which results in irreversible double-strand breaks in DNA and inflammation. Normal cells can repair the cell damage by this process, whereas cancer cells have difficulty doing so. So radiation dermatitis occurs in most radiation therapy patients. More than 90% of radiation therapy patients will receive some grade of radiation dermatitis. And about 20 to 45% of those experience grade 3 or grade 4, but not usually grade 4, dermatitis with moist desquamation and ulceration. Here I've highlighted the areas that are most radiosensitive. And as you can see, these areas are bony and bulky surface areas that are most radiosensitive. So I'm going to just do a term review, which I'm sure most of you are aware of, but just for the context of this course, I want to talk about the terms again. Ionizing radiation is radiation therapy uses ionizing radiation such as X-rays, gamma rays, high energy electrons, or heavy particles to kill cancer cells. Acute radiation dermatitis occurs within about 90 days of starting treatment. Typically, this occurs gradually during a fractionated course of radiation therapy. Chronic radiation dermatitis can present months to years after radiation exposure. It can occur with dermal fibrosis and poikilodermatosis, which is basically an area of irregular pigmentation, and that's usually the part of your body that's most usually exposed to the sun. It can include hyper or hypopigmentation, atrophy, and telangiectasias, which are basically spider veins. Radiation burns are a manifestation of symptoms within weeks of exposure, but long-term effects and it is categorized as a late effect because it can occur months to years after radiation therapy. Depending on the radiation dose and the affected area, the late effect of radiation burn can include skin changes, fibrosis, and tissue damage, and it is persistent. it can be very difficult to identify the injured versus uninjured tissue, as it usually occurs in the area in the field of radiation, the area that we treated. And some of the characteristics include that they can be dose dependent in their clinical pattern and also opiate resistant pain. Radiation recall is an acute inflammatory reaction confined to the area of previous radiation, and this is usually triggered by certain drugs, and we often see this with chemotherapy. So here's your first Zoom poll to make sure you are all paying attention. What percentage of patients receive radiation therapy will experience radiation dermatitis? Is it A, more than 90%, B, 20 to 45%, C, 50 to 75%, or less than 20%? The answer is greater than 90%, which about 67% of you got correct. So essentially, most of our patients will receive some grade of radiation dermatitis. Not all of them will need any advanced treatment for that, but most of them do experience some level of radiation dermatitis. So good job. All right, next we're going to talk about risk factors and prevention. So risk factors include different areas of treatment. So we talk about the body area that we're treating. We talk about comorbid, also some genetic susceptibilities. So areas of the body that are most radiosensitive, we just covered. They tend to be bony prominences and large surface areas. Patients who have had breast reconstruction or implants have a little bit more risk for radiation dermatitis because of the skin's inability to dissipate heat following reconstruction procedures. Surgical sites within the treatment field for the same reason. Those who have larger, more dense breast, that is associated with increased risk of grade 2 or higher radiation dermatitis, and people with darker skin experience worse cosmetic outcomes after resolution of radiation dermatitis. Comorbidities and lifestyle that make a higher risk for radiation dermatitis also coincide with higher risk for cancer in general. So those include obesity, older age, being female, chronic sun exposure, and smoking. And then there are some genetic susceptibilities, which many of us may not see, but those include scleroderma, ataxia telangiectasia, Bloom's syndrome, Fanconi. There's many of them. I just listed a few here, but just be aware that every once in a while we see a patient who has one of these genetic indications for increased risk for radiation dermatitis. The other thing that we look at is what is the radiation dosing and schedule. We are concerned with what is the total dose we'll be giving, what is the cumulative dose, where is the patient at when we are actually seeing the radiation dermatitis, and what is the dose that they're getting per fraction. Patients may have concurrent anti-cancer therapies such as chemotherapy, specifically anthracyclines and taxanes can increase the risk for radiation dermatitis. And then there are targeted therapies such as epidermal growth factor receptor inhibitors that can increase the risk for radiation dermatitis. And then those who have a history of bone marrow transplant or cellular therapy can be at risk, especially if they have any amount of skin GVHD, which is graft versus host disease. So for prevention, we use therapy techniques that reduce the dose to the skin, such as IMRT, VMAT, or SBRT. We typically provide radiation in fractions, but we can also provide hypofractionation, such as to the breast. We currently have some protocols now that allow us to give less dose to the breast with the same or better results. We can do partial breast radiation versus whole breast. And then we talk about the foundations of skincare for any patient who's receiving radiation therapy. We like them to use clean, lukewarm water and mild soap when they're cleaning, moisturize 2 to 3 times a day, including non-treatment days with a water-based gel or cream. And I've included a few here that we typically see. This may not be the same that you use in your clinics, but anything that doesn't have a perfume or petroleum is a good start for moisturizing 2 or 3 times a day. We ask patients to wear loose-fitting clothing over the area of treatment. And sometimes if they are really irritated by clothing, we might recommend that they wear their shirts inside out so that the seams are on the outside, and that way it doesn't abrase the skin. Also, require them to wear sunscreen forevermore in the area that we have treated, regardless of how susceptible your skin is to the sun. Before radiation therapy, we're compromising their skin. So we'll always want them to protect their skin from the sun. And then wearing deodorant helps prevent any breakdown in the creases of their arms or wherever they're wearing deodorant. Things to avoid, we talked a little bit about just now, but perfumes and alcohol-based topicals are not ideal. We don't want them to use cornstarch or powders, especially in the skin folds, because this can cause infection. Avoiding skin exposure if possible. Wet shaving, we prefer patients, if they do need to shave, to use an electric razor. And then extreme exposure to temperature is not ideal. So we don't really want anyone using ice packs directly on the skin or heating pads directly on the skin. We also recommend that patients don't sit in hot tubs or hot springs while they're undergoing radiation, because this can also further compromise their skin. And then a little bit about topical corticosteroids. We see a lot of evidence that using topical corticosteroids right at the beginning of therapy can really help sometimes progress to severe radiation dermatitis. It will not prevent radiation dermatitis from occurring, but it also is very good at preventing that itching that we can sometimes see. So we do sometimes ask our patients to start topical corticosteroid use right at the beginning of radiation therapy. And then we just apply that for in the treatment field 1 to 2 times a day after treatment. It's totally fine to apply before treatment as well. How are we doing? Any questions so far?
Yes, we have a couple. I've answered one. There's a
Okay.
question about how does deodorant help prevent dermatitis?
So we're really talking about in the area of the treatment field. So typically we're talking about breast patients or patients who are having chest wall therapy. If you are if you have any degree of radiation dermatitis, we are disrupting that barrier of heat and water loss. That also includes sweating. And so if you have deodorant preventing the buildup of the accumulation of sweat under your arms, then you're going to reduce the chance of that over moisturization, which we're going to talk a little bit about, which causes breakdown on its own. So wearing deodorant can help keep your armpit dry and not accumulate the moisture that can occur from radiation treatment. So
Yes, I've typed that response in the chat.
thank you so much. Any others?
The other one was how are elders risky to radiation dermatitis? So essentially, if being older makes you more prone to radiation dermatitis. I said it's dependent
Yes.
on radiation dose and length of treatment.
It is. And also, as we age, we have had more exposure to the elements and to the sun. And so we naturally have a higher risk for breakdown of our skin. And as when we get older, our skin thins, our water barrier is less. And elderly people tend to have more dry skin. They don't produce as many cells. So when we are adding radiation to their skin, it's just causing a higher degree of damage.
There's a question about what if the patient's getting radiation to the axilla in reference to the deodorant
So
comment?
we don't Okay. There is no evidence to show that there's a risk. So we used to be concerned with deodorant causing a bolus effect with radiation, meaning that if we had deodorant on the skin and the radiation was given through it, it would provide a higher dose to the skin. They've done a lot of studies to find that is not actually the case unless you had a very thick layer of deodorant or cream on the skin, and it would be more than 6 millimeters thick, which we don't typically ever put on our skin. There are some providers or doctors and centers that say don't wear deodorant, but for the most part, it's not an evidence-based response. So if you work for a clinic that says we don't want you to wear deodorant, that's fine, but there is also not any evidence to indicate that the patient would be damaged by wearing deodorant. The caveat to that is when we do give patients total body irradiation, which is in preparation for bone marrow transplant, We do ask them not to wear anything on their skin because we're giving them a very large dose to their body. So we want everything off of their skin. I think you're muted.
What type of deodorant is allowed?
I don't, do you mean, can you clarify that question?
I guess it's not specified, but that could mean scented,
Of-
non-scented, these
Yeah,
ones that don't have metals in them or aluminum
sure,
in
sure.
them. Yeah.
Yeah. So I would say that most deodorants have aluminum, and that's probably maybe where your question is coming from. Aluminum also is not indicated to increase the dose to the skin. But as with all recommendations, we want to use something that's mild and doesn't have alcohol or scents that will be irritating to the skin. So anything that you can use that's hypoallergenic or mild would be preferred.
Okay.
All right. So we will move on now to nursing assessment, diagnosis, and grading. And thank you for those great questions. So for nurses, skin assessments are much more than just assessing the skin. We have to really use our critical thinking. During your baseline assessment of the patient, which is the assessment that you do before we ever start radiation therapy, it's really important for you to look at the skin in the area that will be treated. It doesn't seem like something that you would need to do, but we really need to know where we're starting from so that we can monitor what changes are occurring with the patient. So what does it look like now? And if there are any expected findings, like there's a surgical site or the patient has a birthmark or they have had some injury to that area, just note those unexpected findings so that they're not later identified as new. And then every on treatment visit, when you have the opportunity to assess the patient, eyes on the patient's skin in that area that's being treated. This will look familiar to you because we reviewed the nursing process in our prior lecture, but assessment is the first sort of initiating component of the nursing process. So we always do a full review of the patient's health in the initial baseline nursing assessment because that informs our care through the science of the nursing process. What did it look like before treatment started? And did you document that? There are a lot of radiation oncology clinics now that are using photo documentation, and we don't all have the benefit of that. But if you have the benefit of being able to take a photo of your patient's skin at each visit, it's very helpful in informing our care of the patient. But totally fine if you cannot. I don't currently work in a clinic where we do photo documentation, but it is a very good practice if that's available to you. So some of the things that we are looking for, is it expected? Are we looking at the skin of a patient who is currently being treated? What is the treatment modality that we are treating them with? Are we giving them a short course of SBRT or are they on a standard 5 to 6 week course of daily treatment? How much radiation have they received at the point we're looking at their skin? And is the skin that we're looking at that's having a problem even within the treatment field? And what does that look like? Is it red or pink or hyperpigmented? Does it look wet or shiny or irritated? So this is not something for you to memorize. It's just a reference and it's not exactly 100% accurate. It's just a guesstimation of where we see skin changes according to dose of radiation. So what dose have they received in their radiation treatment? There's many factors that relate to whether and how severely a patient will experience radiation dermatitis. This table just represents a general snapshot of acute and chronic skin effects related to doses. For example, in this table, a fractionated course of 2 gray per fraction of radiation therapy, erythema occurs at doses of 2 to 20 gray. And then dry desquamation occurs at doses greater than 20 to about 25 or 30 gray. And then moist desquamation occurs at doses greater than 30 to about 40.
Ice cream.
And then I just included this. I don't know how many of you have experience with proton therapy. We have one center here in Seattle that we do treat with proton therapy, but just for a clinical reference, wanted to let you know that proton beams are measured in CGE, which is cobalt gray equivalence, and it's basically calculated by multiplying our gray by the factor of about 1.1. There's a variation. So all that to say that a patient who is receiving proton therapy has a similar response as a radiation dose with photons. Okay, next we're going to talk about our nursing assessment. So we're looking at how is the patient experience. It's our job to monitor along with our caregivers, but it is our job to monitor how is the patient tolerating their treatment, because we are the advocates for our patients and we want to make sure that we are helping them get through their treatment. It's very important, as we spoke about last time, for them to complete their therapy and to complete all of their treatments. So what is the patient experience? Are they itching? Is it painful? And if it's painful, we use something with a mnemonic called old carts. And I don't know if you've heard this before, so I'm just going to go over it really quickly. But when we're talking about pain, we want to know, what is the onset? Did it happen suddenly, or has it gradually been coming on? What is the body part specifically we're concerned about? Is it in the radiation treatment field? How long does it last, or is it ongoing? What are the characteristics? Is it burning? Does it feel tender? How is it affecting them? How do they perceive it? What makes it better or worse? Radiating or alleviating factors, such as adding some cream, may stop that irritation or pain, or maybe it will not. And then what's the timing? Does that happen all the time, or does it only happen 2 hours after they finish their treatment? And then what's the severity? We use a scale of 1 to 10, 0 to 10 here. And sometimes patients can say, this is a 5, it's really not comfortable, but I can tolerate it. Or maybe it's a 7 or 8 and I can't even sleep because it's bothering me so much. So those are the things that we're looking for, because we know that a patient's pain is what they experience it to be. We also want to be concerned with how it's impacting their quality of life. And so we look at activities of daily living, which includes, are they able to bathe and dress themselves and undress themselves and feed themselves, use the toilet, take their medications? We think about head and neck patients who have trouble with swallowing sometimes. We think about breast patients who may not be able to sometimes lift their arms because they may be getting some irritation or tightness of the skin. So we just want to be really thoughtful about noting how the patient is experience radiation dermatitis. And then also, are they on concurrent therapies, or do they have individual risk factors such as eczema that might be increasing the effect to their skin? And of course, we always want to check and make sure, are they complying with the skincare regimen that we have discussed with them? It's important for us to make sure that we're having a conversation with the patients and their families so they know what we would like them to do for their skincare, but also, are they doing that when we've asked them to do? All right, so nursing diagnosis. We know that there are some particular manifestations of radiation dermatitis. Manifestations are the objective observable findings. And so due to the increased melanin production in darker skin, radiation dermatitis may appear as darkening or hyperpigmentation rather than the typical redness in the lighter skins. So even though this does not look irritated, you can tell that it is a darker pigmentation. And so that would in fact be, if we were treating that area, a radiation dermatitis. So this is where we use our nursing critical thinking. What might be happening? Is it radiation dermatitis, or maybe is it something else? Using our clinical nursing judgment, we consider, if it's radiation dermatitis, what's the grade? Because this informs our nursing interventions. And we're going to talk more about grading here in just a second. But the other thing I want you to think about is, could there be a differential diagnosis? And so that means, if we are seeing something that may look like a radiation dermatitis, could it, but maybe it's not the right timing in there, maybe it's too soon in their therapy where we may not expect to see it, or maybe it's worse than we expect to see. Could there be a differential diagnosis? Is there maybe something else that's happening? And how are we doing with questions?
Good.
Doing good?
Same
Great.
level.
All right, so we use two grading scales. We typically use one grading scale. It's called the Common Terminology Criteria for Adverse Events, or CTCAE, and the current version is version 5. But just to note, there are some institutions that use the radiation therapy oncology group criteria, which is RTOG for grading radiation dermatitis. But just know that both scales use the exact same criteria. So when we're grading radiation dermatitis, it's not necessary for us to cite which scale we've used because they are the same. But for the purpose of this class, we're going to be talking about the CTCAE criteria. So grade 1 radiation dermatitis, as you can see in this photo, is a faint erythema or dry desquamation. And as we just talked about, for darker skinned people, that could mean a hyperpigmentation. On the left here, you can see a person who's just beginning to get that irritating red erythema, but it's dry. On the right, that is a darker tan pigmentation. That's actually a photo of someone who is recovering from radiation dermatitis, but that is also what a grade 1 radiation dermatitis would look like. Grade 2, we're talking about moderate to brisk erythema. And I'll talk a little bit more about what brisk erythema means, but it's patchy, moist desquamation, not always moist desquamation, but typically if we do see the moist desquamation, as you can see with the arrow here, it's mostly confined to the skin folds and creases. And there's a moderate amount of edema here. So it's really beginning to look angry. And then when we get to grade 3, we're looking at areas of the skin that have moist desquamation that are not just in the skin folds. You can see here, we can't necessarily see where the skin folds are because it's a little bit more diffuse. So this can also, in grade 3 radiation dermatitis, can also be indicated by bleeding that's induced by just maybe a little scratch or minor trauma or abrasion, or even just the seam of a shirt really irritating that area. And then this is a photo of grade 4 radiation dermatitis. It is something that we typically do not see in a clinical setting outpatient. Usually, if this is going to occur, we have long since stopped radiation treatment, hopefully, and these patients are probably in the hospital because they will likely need a skin graft. But as you can see with this person, they just are having spontaneous bleeding and it's full thickness, full dermal thickness that they have had this radiation dermatitis. And then of course, grade 5 would be death, which we hopefully do not also see in an outpatient setting. So I'm going to go a little bit more in depth into these grades. Important to note is that grade 1 and grade 2 radiation dermatitis are differentiated by the degree of erythema or redness. Erythema we see in a lighter skinned person as that salmon pink color. And it could also be light brown, or you may mildly notice hyperpigmentation. Salmon pink erythema occurs before progression to a more serious dermatitis, and light brown erythema is typically found on recovery from dermatitis, as we talked about earlier. Erythema means that skin is red or irritated due to the increased blood flow to the capillaries in the skin, and occurs with any skin injury. So it's not just radiation that causes this. It could be infection, it could be inflammation. And so we talk about this salmon pink color for lighter skin, but then I wanted to talk a little bit about what brisk erythema means. And brisk erythema is this really bright, moderate to bright redness in the skin. And even with darker skin, sometimes it can have a really dark or even deep red hue to it. So this is technically a grade 2 radiation dermatitis on the grading scale. But note that this distinguishing difference between grade 2 and grade 3 that is clinically significant is that we can see that there are skin folds that are the whole entire area is not excuse me, broken down quite yet, whereas grade 3, there's more diffuse breakdown. And then grade 4, as I said, hopefully we will not see this in the outpatient setting, but spontaneous bleeding, this can be life-threatening. There's often skin necrosis or ulceration of the full thickness of the dermis, and usually these patients need a skin graft. And then I just wanted to share this is a head and neck patient, obviously, but this would be the trajectory of radiation dermatitis with healing. So this is 14 gray. Then we move on to about 38 gray. And then we're moving on to 54 gray. So we're starting to see that grade 2 radiation dermatitis. And then 66 gray, we're here at definitely grade 3 radiation dermatitis. And then this is about 10 days after radiation therapy has stopped. And you can see that healing has already begun. So he's regressed to about a grade 1 radiation dermatitis. All right, next Zoom poll. So we just talked about the CTCAE grading scale. CTCAE grading scale provides a clinically significant difference between grade 2 and grade 3 radiation dermatitis. Moist desquamation, mostly confined to the skin folds and creases, is grade 2 radiation dermatitis. True or false? All right, really good. 87% of you said that the answer was true, and the answer is true. Grade 2 radiation dermatitis can be distinguished from grade 3 radiation dermatitis by the beginning of that moist desquamation in the skin folds. Also important to note is that grade 2 radiation dermatitis doesn't always have moist desquamation. So this is where our critical thinking and clinical judgment comes into play. Very good. Thank you for your participation. Next section is planning, implementation, and documentation. So this is actually a snippet from the CTCAE version 5, which has the actual section on radiation dermatitis. But let's suppose through our nursing assessment and critical thinking that we've concluded that this patient we're seeing is experiencing radiation dermatitis. And we use the CTCAE grading scale to determine the grade. Now we need to pull from other areas of our nursing knowledge. So I wonder if you recall the general principles of wound healing. And if you don't, I'm going to go over them really briefly. What do our patients and their caregivers need to know? They need to know who and when to contact if their skin progresses beyond a point that we would want them to manage on their own. And if the patient requires any topical treatment that may require, let's say, a prescription, as nurses, we are facilitating that with the radiation oncologist and making sure patients really do understand how to use those prescriptions. We reinforce the importance of nutrition and hydration. So we will have a talk on that next time, but really making sure they're getting enough fluid intake because we're impacting that primary barrier of fluid loss. And also protein facilitates healing in our bodies. And then we need to develop and implement an integumentary plan of care with them, which means making sure they understand what we want them to do for skincare and hopefully making sure they're actually doing those things. All right, so principles of wound healing, just a quick 101. I'm sure you all went through this in nursing school, but brief review. Cell growth needs moisture, and the principal aim of moist wound therapy is to create and maintain optimal moist conditions. So wound exudate serves as a transport medium for a variety of bioactive molecules, such as enzymes, growth factors, and hormones. And wound exudate also provides different cells of the immune system with ideal conditions to destroy invading pathogens, such as bacteria, necrotic tissue, etc. And then that protects us from infections. So moist wound treatment is known to prevent the formation of a scab, which allows epithelial cells to spread horizontally and outward through the thin layer of the wound. And so the main thing that I want you to recall here is that wound exudate is key. It's the transport medium for everything that we need to heal and provides ideal conditions to prevent infection. However, not all exudate is beneficial, and we'll look at some exudate and go over those. But if we see something that's purulent or bloody or there's excessive drainage, that can actually be harmful and prevent the healing that we're looking for. So here are some examples. I want you to think about the terminology that we use because as patients progress in their radiation dermatitis beyond a higher level of grade 2 or into a grade 3, we're now talking about a wound. So on the top left, and I apologize for using only light skin photos, but I feel like These were the best photos I could find to really demonstrate what we're looking for. But erythema is just the redness of the skin, and there is some increased blood flow in the superficial capillaries. And then on the right, dry desquamation with flaking. It's probably itchy. It's almost to the point where there's going to be some of that moist desquamation, but not quite. And we can see that this patient is probably going to progress to moist desquamation. And then moist desquamation here, usually pretty painful, starts to be very tender. There's serous fluid and maybe some sloughing of the dermal layers. And this is a lighter skinned person who has hyperpigmentation. So the skin appears darker than normal in some areas and usually is related to healing of radiation dermatitis or radiation recall. And then wound bed, we think about the actual area of the wound. So epithelialization is what we get anytime we scratch our skin. It's just that denuded epithelial surface is covered by a layer of epithelium, and it just seals the wound to protect it from the environment and usually heals. When they have a much deeper wound, we're talking about granulation. So tissues made up of new blood vessels, fibroblasts, I apologize, and inflammatory cells to help protect the wound from infection and fill it with new tissue. These are both good, normal ways that our skin heals. This bottom picture of slough and crust, this is what we do not want to see. So this is a mixture of fibrins and white blood cells and bacteria. It may indicate an unclean or stagnant wound environment, and it increases the risk of infection and prevents healthy cells from migrating and repairing the tissue. So all that to say, sometimes it's difficult to tell the difference between a slough or crust and maceration, which we're going to talk about in a minute. If you see something that's looking brown or brown and weepy or moist, or yellow and weepy or moist, then that is something we want to clear from the skin because that is no longer helping the skin to heal. The next section is eschar, and that is dead tissue. We also call it scabs sometimes, but it's dead tissue within the wound, typically tan, brown, or black, maybe crusty, and it really makes it difficult for us to see the wound. So it's no longer promoting healing in the wound bed, and we do need to remove this for a wound to heal well. This is the time when you want to have your radiation oncologist, or if you have a specialist like a wound care specialist, get involved with your patient care or teach you how to take care of this type of wound. And then this is the drainage part. So serous fluid is, excuse me, the clear, thin, watery plasma that we typically see when we're talking about moist desquamation. It's usually not profuse or copious. It's just a little bit of clear fluid. Purulent is what I was talking about. That can be that thick, opaque, yellow, green, brown, tan, whatever color. And it's never considered normal in a wound bed. And this is purulent dressing drainage that we should always be reporting to the radiation oncologist or care team, and also make sure that we're managing because this could indicate that there's an infection or an infection brewing. Serosanguinous drainage may be slightly normal if you're talking about a patient who has grade 3 radiation dermatitis and they're having just a little bit of sensitivity in the area and maybe they've scraped themselves, but it is also not something that we want to see. It's a little bit of blood with more moderate to heavy drainage. And then sanguinous drainage is just fresh bleeding, which we do not want to see in an area of radiation dermatitis. So it's important to be able to use these terms to describe what you're seeing in your documentation. It's also important to quantify what you're seeing. Is it just a minimal amount? Is it pretty moderate? Is it heavy and copious? Because that all impacts how we're going to care for those patients. And then we also want to talk about what does the surrounding area of the wound look like. So maceration is something we don't want to see. And maceration, we think about any wound that is too wet, or think about standing in a bath for too long and your skin gets that kind of crinkly white looking surface to it. It's caused just by excessive moisture. And so this is an example of a pressure sore. The tissue is really got no pigmentation in that area, and it's really soft and soggy. And if a patient has this within a treatment field where they're experiencing radiation dermatitis, there is no capacity for healing in this area. This part is called induration, and we sometimes see this as an orange peel appearance on any color of skin. And it's really just an abnormal firmness of the tissue where with margins, and sometimes, like I said, it has that orange peel appearance. It really is often seen in areas that have had some injury prior to radiation dermatitis, but it is difficult to heal with induration, so it's something that we would want to note. And then we typically do not see this in radiation dermatitis. However, I have had a few patients who we have been treating their spine, and so we've seen maybe some pressure ulcers in the area, and radiation dermatitis can really progress this problem. But undermining is that sort of shelf-like injury. The sinus tract is when, for instance, this photo, it has an entrance, but it doesn't have an exit. And then a tunnel has an entrance and an exit. And these are really more advanced skin issues that can occur within a treatment field where you would want a specialist to be helping you with skincare if you didn't have the expertise. So a review of signs of infection: redness or swelling, warmth of the surrounding tissue, tenderness or pain, purulent drainage, fever, of course. And if you have the benefit of knowing what your patient's labs look like, they may have an increased white blood cell count. So implementation, we know in nursing to be our interventions, and with radiation dermatitis, we use a step-up approach. So let's talk about how to implement our nursing interventions. Unless prohibited by your nursing credential or license, radiation oncology nurses manage grade 1 radiation dermatitis independently. And we do that by using patient education materials, whether those be printed or photograph or handouts, or even our personal discussion with the patients. And then we use our skincare guidelines, whichever those guidelines are within your clinic. Where do you start with radiation dermatitis prevention and care? If there's progression to more than grade 2, or the level of grade 2 where moist desquamation is beginning, you want a doctor assessment, especially if they have grade 3 radiation dermatitis. You're going to want your provider assessment, and if you have access to a wound care specialist, that might be a good time to request a consult. We provide, as nurses, ongoing dressing changes and wound assessment every time we see the patient, and we manage and provide recommendations to our doctors for skincare modalities, because we as nurses can specialize in that for our patients. And I think our providers very often will take into consideration what we are recommending. So for grade 1 radiation dermatitis, we continue the general skincare that we've recommended at the beginning. We still want our patients to use a mild soap. We still want them to use daily moisturizer and protect their skin. There's no required specific treatment in addition to these, except for patients may feel itchy, and so maybe they might want to use a little advanced skincare like a barrier cream. And so in my clinic, we sometimes will ask them to use Aquaphor because that can be thing. For grade 2 to grade 3 radiation dermatitis with moist desquamation, we typically use soft absorbent bandages, because remember, we want to maintain some moisture, but we don't want the skin to become too moist and macerated. Bacterial infection is typically treated with topical antibiotics first, but then sometimes we might need to use a systemic antibiotic if we really feel that there's an infection going on. And often we will do a wound culture to, if available, to test and see what kind of infection we're dealing with. Patients with grade 4 radiation dermatitis, as we talked about, if they present with the full thickness skin necrosis, may require surgical debridement and full thickness skin graft. And typically we've stopped radiation before we reach this point. And then patient and family education will always continue. Every time you see your patient and their family, you want to continue reinforcing the education and their skincare regimen. And it's really better if you have the opportunity to ask them to reteach you what you have taught them to make sure that they understand what we are expecting from them. Now we're going to talk about documentation. And I just want to review that knowing your terminology is key. We know that radiation dermatitis is erythema, desquamation, hyperpigmentation. We want to talk about where we're seeing the dermatitis, where we're seeing the desquamation, and we want to know, is there bleeding? It's also really important to know, to recognize what you don't know. And it's okay not to know something, but we just need to know what our resources are. Do we have access to a specialist? Is it time to bring in the radiation oncologist to take a look and make recommendations? So baseline assessment before treatment begins, we're going to make sure to do a really thorough description of what the skin looks like to begin with. On our on-treatment or weekly visits, we're going to lay our eyes on the skin every time to make sure that we know if anything has changed. Patients are not always as observant about what's going on with their own skin, so it's really important for us as radiation oncology nurses to make that assessment. Make sure we're using a grading scale that has criteria that's recognized universally so that anybody who's looking at the chart will know if this is grade 2 radiation dermatitis, this is what that means. And then, as I mentioned before, if you have the opportunity or access to photograph the skin, that can be really useful in monitoring the progression of radiation dermatitis in a patient. So we want to document the signs that we are noticing. So the objective assessment, erythema, dry desquamation, etc. We also want to document the symptoms the patient experienced, their subjective experience. So pain, as we talked about, itching, burning, warm. Is it having an impact on their activities of daily living? And then we want to identify the location and the grade. And if there is a wound, we just went through that terminology. Include as much information as you can because that's going to be helpful for you or another nurse or another doctor or specialist to understand what it looked like before as opposed to what it looks like now. And then for interventions, we always want to document what plan we have created with the patient and for the patient, what education we have provided to them, what treatment recommendations we've made to them, whether that be topical cream or soaks or cleansers or dressings. And also, is that recommendation effective? Is it actually helping the patient with their symptoms and their radiation dermatitis? Any questions we can answer so far? Okay, I will move to our last Zoom poll. So this patient is experiencing moist desquamation, mostly confined to the skin folds and creases. What grade is this radiation dermatitis? Is it grade 1, grade 2, grade 3, or grade 4? All right, time's up. We have 6% say it's grade 1, 65% grade 2, 28% say grade 3, and 1% says grade 4. So the answer to this one is this is a grade 2 radiation dermatitis. We see that there is a little bit of moist desquamation developing, but it's clearly just in those skin fold and crease areas. Thank you all for your engagement. So take-home points I want you to remember are that we as radiation oncology nurses have the confidence and the specialty to provide nurse-driven assessments and manage patients experiencing radiation dermatitis. It's important for us to have the confidence to assess skin and the skills to manage skincare. And that is something that comes not only with time, but also experience. And those clinic guidelines that you have for treating skin may differ across clinical sites, but generally speaking, it's a basic skincare regimen. We're just asking patients to keep their skin moist and protected because we are impacting their ability to do that by providing radiation to the skin. And also maintain your evidence-based knowledge of radiation dermatitis There are lots of resources about radiation dermatitis. There's not a lot of really strong evidence about how we should or shouldn't treat radiation dermatitis, but as nurses, we know with our experience what works and what doesn't work, and that is a really important perspective to advocate for our patients and care for them. So if you weren't here last week, or if you heard me already, I keep this quote next to my desk. It's very helpful for me caring for my patients, but we walk with our patients no matter how turbulent the journey. And we know that our patients have varying degrees of severity in their cancers and their responses and their side effects. And so I really thank you so much and appreciate everything that you do. And I would be happy to take some questions.
Thank you very much, Sunshine. That was excellent. And everyone, I hope we all learned something. And we had a couple of questions, and I tried to answer along the way. There were
Okay.
questions related to a large breast being a risk factor for dermatitis, why darker
Yeah.
skin have more dermatitis, the best way to treat a wound with a slough. And
Did you want?
yeah, if you could answer those, and I'm
Okay.
going to find a slide to share with everyone, my own contribution.
Sure. So darker skin or more melanated skin has a higher risk for radiation dermatitis because those cells in the skin, if you have more of them and they have a higher turnover, they're also more radiosensitive. So you can have a much greater impact to the skin. It doesn't mean that the dose to the skin is any different. It just means that the cells in the skin respond differently. So that is why melanated skin tends to be more reactive to radiation. Denser breast just means that you have a greater surface area. If you think about anything that has a greater surface area, if you provide radiation to a greater surface area, you're going to have a greater impact. And then what was the other one?
I'm treating a slough.
Oh, treating slough. So that usually, it doesn't require if you have the specialized knowledge, but it is important to remove that usually with a saline rinse. So we usually try and gently scrub that. We used to do wound scrubs. We don't do those anymore. They used to do wet to dry dressings. We don't tend to do those anymore. Thank you so much for the very sweet comments. I appreciate that. But it's really important just to remove that top layer if you can. Sometimes that does mean just soaking and gently scrubbing. Sometimes we do that in a bath, just letting the water run over the skin. But if we don't remove that slough, then we're not promoting good wound healing. And then evidence-based practice for grade 2 radiation dermatitis. So there are different thoughts on how best to treat radiation dermatitis. And the fact of the matter is that it really depends on what that radiation dermatitis looks like and what is behind it. So if we're talking about a grade 2 radiation dermatitis that really just is itchy and a little bit irritative to the patient, we might use something like Aquaphor that does have a little bit of petroleum in it, but is very soothing, and we just ask patients to use that a couple times a day. If you're talking about a radiation dermatitis grade 2 that has moist desquamation and it's starting to look a little, it might become angry, then maybe you might use some Silvadene to prevent any type of bacterial infection. You might want to use probably not a dressing unless it's got some copious drainage, but basically it depends on what the wound looks like. And the evidence I tend to use something called Up to Date. I don't know if you have access to that, but any resources that you have that have peer-reviewed, evidence-based information is going to be a good resource for what has changed, because there are constantly clinical trials and studies going on about what's best to do for radiation dermatitis. And as I said before, there isn't a ton of evidence about what the best things are to do. So I recommend that you use your nursing clinical critical thinking and your critical inquiry to really look around and see what you can find for evidence-based treatment, because oftentimes our radiation oncologists are relying on us to provide those recommendations to them.
Excellent. I'm just going to add a few words at the end. So
Yes,
I
please.
primarily treat breast radiation, and the For darker skin, it has been suggested that in addition to using the grading scale of dermatitis, hyperpigmentation grading is also suggested because our skin tone tends to be just get darker with radiation as you progress towards the end of treatment. And majority of you in your countries are probably still using standard fractionation. So you're going 50 gray over 25 treatments over 5 weeks. And by the time you get to the fifth week, it's very dark. And then there are patients, when it comes to moist desquamation, darker skin tends to peel usually in the armpits and usually under the skin fold, the inframammary fold. For the for the audience, I try to find, I was born in Nigeria, but I did my schooling and education in the US. So I try to find relevant medication substitutes for the words we're using here in the US for what would be used in other African countries. So if it's grade 1 here, in my practice, I just tell women to use Aquaphor. Aquaphor's conversion would be like Vaseline. So like petroleum jelly, Vaseline. You don't want them putting Vaseline on their breast when they're about to walk into the treatment room, right? But when they're getting on, when they come in, should be completely dry. It's okay to have deodorant on, but their breast should be completely dry getting on that table. When they get off the table, they can bring the Vaseline with them, put it in their bag. Once they're changing, after treatment, they can apply the Vaseline on. Later at night, apply it on again. And you want to do it along the lines that you're treating. The treatment field gets obvious by the third and fifth week on the breast as a clear demarcation. But from week 1, teach them to start from the clavicle down to underneath the breast, 2 centimeters below the breast, midline, and the mid-axilla. So do that generously, grade 1. Grade 2, let them continue that. And I tell them to continue this for an additional 2 to 4 weeks, even after treatment. If you're starting to notice some peeling, dry desquamation, moist desquamation that you're noticing, then you want to be a little bit more careful because now cleaning and making sure that area is infection free is very important, right? Because now you're exposing subdermis to air and all types of things. So first, they're going to be very uncomfortable. If they're large breasted, get rid of the bra and sports bra and tight bras with wire, and let them air out the breast. When they're in the house by themselves, put a standing fan, and air out the area. If you're noticing peeling, soaks. So here I use Domboro soap, which is a packet we pour into sterile water, and we ask them to soak some gauze in it and just apply it over the area and then let it dry off. The equivalent for you all would be something like Dettol. And I know we use Dettol sometimes to sterilize our water before bathing, but something like a Dettol, small amount, not a high concentration in water, just to clean the surface area. And then let it air out and dry. And then instead of Aquaphor now, because you have open areas when you're talking about grade 2 and you're looking at desquamation, now Sunshine mentioned Silvadene. So the alternate for that is Darmazine. So essentially some type of silver nitrate treatment, silver sulfidine treatment. So that Darmazine would be what you would tell them to put under those open areas. In the non-open areas, they can continue to use Aquaphor and things like that. Typically, if I know a patient is going to be treated going towards here I use hypofractionation and sometimes 1 week of radiation. But if I have an inflammatory patient, for example, I expect they're going to get desquamation. So I don't necessarily start off with Aquaphor. I just go straight to something called mometasone. Mometasone has a steroid component to it, and let me find the like it has a steroid component to it. I'm trying to look for what it's also known as Nasonex. But this is a cream that you're supposed to put on your skin and it has steroid in it. So I usually just start it from the first day of treatment and have them stay on it for up to 2 weeks after treatment. And I find even in head and neck patient, it works great. In breast, it works excellently. And it reduces the appearance of hyperpigmentation, and worsening dermatitis as they go through treatment. So if you have something that's similar to mometasone, I would strongly suggest that as well. Now, another thing that can happen is itching. Along the chest area, some women may start to report feeling like they're itchy. You want to encourage them not to itch. If it's really bothering them, applying a cool gel, so maybe put the Vaseline on when it's a little cold. It takes the edge off from itching those surfaces. Because if they're itching a skin while we're doing radiation, it's going to cause it to become blisterous, and you can form blisters and it can open up, and then you can start to have wound issues. So you want to encourage them to stay away from itching. If they can get access to hydrocortisone cream, anti-itch cream, don't put it all over the breast, but those itchy spots on the chest, they can just put it there just to help take the edge off. So that would be my contribution to all of this. I'll stop here. Are there
Thank
any
you
questions?
so much.